This session is really us showing you the Theranostics Dream Team. It's about the expertise of a high-volume centre, of which Peter Mac clearly is. My name is Stephen Stuckey. I'm the Medical Director of Cancer Imaging.
Thanks, Stephen. And my name's Brittany. I'm the lead Nuclear Medicine Technologist for radionuclide therapy at Peter Mac. And our first speaker today is Lisa MacFarlane, and Lisa is our Nuclear Medicine Technologist ProsTIC Coordinator. Thanks, Lisa.
Good afternoon, everyone. So I'm here to talk about our part in the Theranostics Dream Team. Now, I was going to do a big spiel on what makes an awesome dream team, but Ziting's already talked all about all the elements of that. But suffice to say, it's not just one group of people, it's actually a whole group of people that are required to do a full service. These are some of the people who have worked with us over the years, if you recognise yourself in the backgrounds. So I'll move on to getting on to the treatment day. So we order our lutetium 2 to 4 weeks in advance. Depending on your centre and where you get your lutetium from, you could order that however you do that. Now, you can order it as a unit dose that comes readily delivered, ready to put into a patient. You may get a multi-dose vial that goes into an automatic dispenser. Or at Peter Mac, we actually have an awesome radiopharmaceutical sciences team led by Mo, and so they make the stuff for us. And the key things they need to know is, are they making 617 that day, or are they making INT? Are we using lutetium? Are we using terbium? And so that's also good for them to know. Question that often is asked is, what happens if you've got all your patients turning up and then lutetium fails or isn't delivered? And you may have had experience of this. We had it happen to us last week that one of our suppliers failed production. I guess the key thing in this situation is open and honest communication right at the get-go. So we had a few trial patients that were affected, as well as some compassionate access registry patients. So getting onto the trials team early to let them know what was happening so they can coordinate the treatments that those patients would be affected by. Letting the patients obviously know whether they were going to be affected, whether they were going to be treated. Letting the nursing staff and the technologists know, because, for example, last Thursday we were due to treat 12 patients. All of a sudden those nurses and those technologists had no patients to treat, so they could be redeployed to other parts of the hospital that needed them more. Letting the doctors know so that they could also move their services around. And being in contact with the suppliers, could you actually get some lutetium from somewhere else? Unfortunately, last week we couldn't. And then it's just a matter of keeping all of those communication channels open so that you know when you are going to get it, that you can then reorganise those patients. Having a good admin support team is also critical in this situation, because admin are the people that are going to reschedule all of the appointments, likely contact the patient, send out the reminder SMSs. But generally it works and everything goes fine, and so prior to dispensing we want to make sure firstly that the radiopharmaceutical has passed quality, and secondly that the dose calibrator QC has passed. So as I mentioned before, you may actually get the doses sent to you or ready to go, but because we get our lutetium PSMA made downstairs in our basement 2 lab, it comes up to us in a multi-dose vial. And how we dispense from that is manually. We put a spinal needle in with a rubber bung, and then we use that to dispense our doses. So the dispensing is done by 2 technologists at Peter Mac. How it's done at your site may differ depending on how your trainees are done. And we have a hot tech, and they use PPE, which is a plastic gown and 2 gloves, to dispense according to the order that is given by the doctors. And then you've got the cold tech, who is actually writing down on the dose sticker what the calibrator readout is, and also double checking that what we're measuring is correct and it matches the order that the doctors is given. Now, we generally dispense in a 5 ml volume. That's important, and I'll explain why in a moment. If the patient has a CVAD, we'll use 10 mils, and if the volume that we get from the B2 lab is suitably large, then again we'll also use 10 mils. So on treatment day, the patient arrives and is admitted as a day patient. When they come into the department, we'll check their weight and height. We do that every time, so if there's any changes over the 6 weeks, we can actually note that. We might need to adjust doses if need be. Put the cannula in, take bloods if need be, administer pre-meds if needed. And then we start a saline infusion running at about 250 mils an hour, and we do that via an IV pump. And what we want to do is hydrate the patient. Normally we do suggest to the patients that they come hydrated anyway, but also what we want to do is make sure that the line we've put in is patent. What we don't want is an extravasation of lutetium at this point. So once they've had at least half an hour of fluids go in, the doctor then comes along and we do a timeout prior to connecting the dose to the patient to make sure that we've got the right patient, we're giving them the correct dose and the correct type of dose. I know in some centres overseas you can only get 617, but in Australia we can also use INT, so you want to make sure you're giving the right amount and the right thing. So it's kind of a bit hard to tell, but what happens if you've got the line here which comes from the pump, which is running the saline, we've got a 20 ml flush, and we've got the 5 ml syringe of lutetium PSMA, and this is a 5 ml volume tubing that runs to the patient. And what happens is the doctor will come and load the lutetium into that 5 ml tubing, and then we'll start the infusion at 50 mils an hour, and it goes for about 10 minutes. So when we say to our patients that you're going to be in the department for about 2 to 3 hours, in actual fact, the administration only takes 11 minutes, but it's the coming in, doing all the checks, getting the vitals done, doing the pre-hydration and doing the post-hydration, which takes so long. And it's good to let the patients know that. So once the lutetium pump has finished going through, we then flush the syringe to make sure that everything goes into the patient. We do a calibration afterwards to make sure that we know exactly what the patient has received. And then we give post-administration, again at 250 mils an hour for another 100 mils or so. Once that's finished, we then send the patient to the toilet, and then we do a 2 metre dose rate reading to make sure that they're safe to leave. Now, I've heard in other talks that some patients are admitted for 1, 2, 3 nights. I also know that there are some centres where they don't even bother with the saline infusion. They'll pretty much just give the PSMA and then send the patient home. Local rules are key here, so whether you're following the guidelines, as we've already heard, however you choose to do it in your department is how you should be doing it. So if they have a suitable dose rate reading at the time of discharge, we then take the cannula out and send them home with the appropriate radiation safety instructions. So what we want to document is what they've had, as I said, whether it's INT or 617, whether it's terbium, whether it's radium, height and weight, and the decay-corrected dose, because this information is put into our SPECT imaging cameras when we do the post-treatment imaging afterwards. And this is the 2 metre dose rate here. We want it as a reading under 9 microsieverts per hour. We also record the dose in EPIC. EPIC is our electronic medical record. It's actually covered, it covers the whole of the precinct. So if clinicians at the Royal Melbourne Hospital or the Royal Women's have patients who are also having lutetium treatment, obviously not PSMA, then they can actually see what was received, who gave it, and what the dose rate reading was at the time of discharge. So another question that often gets asked is about what happens with radiation safety. What happens if there is a spill? What happens if the patient is incontinent? First thing is knowing that there is a spill kit handy, that you know where it is, and that you know how to use it. You're needing to know what was spilt, where it was spilt. Was it spilt on a patient? Was it spilt on a staff member? Was it spilt on the floor? Can it be contained? If it's at the end of the day, can you just put a big sign up and leave it to decay for the next couple of days, or do you need to clean it up? This is all important to know. Safety first, always. If you've got survey monitors, knowing what they do. For example, this one here is an alpha detector, so if you've spilt betas, this is useless. This one here actually measures all types of radiation, so that's better in most situations. And then once you've cleaned it up, we have a hand and foot monitor that we can then monitor ourselves to make sure that we're not tracking radiation through the department, and that's used after dispensing, pre-dispensing, as well as at the end of treatment. So post-treatment imaging, is it important? Kerry's already told us that it is, so I won't dwell on any of that. Suffice to say that we do perform this at Peter Mac for nearly all of our patients, unless there's some extreme circumstances that they can't come. And we've seen some pretty pictures on why it's useful to do that. So this is a live patient after 6 cycles, so it was really nice to see that. So we do a 3-bed SPECT, plus or minus the whole body, depending. Some trials actually require the whole body as well. Medium energy collimators, depending on what, whether you're using lutetium or terbium, you might want to change your time per bed, CTAC at the end, and then post-processing with quantitative analysis. Why is that important? It's useful. If you're doing a whole body, you can get percentage retention. This is a really nice number to use. You can correlate with clinical symptoms. You can also see if there's any further sites of disease. And with that, I'd like to say thank you.